Hello, I'm Yasser Janab, interventional cardiologist in Tehran Heart Center, presenting the topic complete heart block during mitral paravalvular leakage closure. Paravalvular leak affects 7 to 17% of patients with mitral valve prostheses, resulting from annual calcification or defective suture lines due to technical error, suture failure, annular disruption, and endocarditis. The recommended intervention is to reduce surgery unless prohibited by high surgical risk. However, transcatheter closure methods have been the favored approach in the previous decade due to being safe, effective, and less invasive. In this report, we present a case of severe PVL after mitral valve replacement and pulmonary hypertension who experienced complete heart block during transcatheter PVL closure. The complication is scarcely reported. Our case is a 60-year-old female with history of MVR and prosthetic valve 12 years ago. She had worsening exertional dyspnea in the past 3 years. Electrocardiogram showed atrial fibrillation rhythm with left bundle branch block. Transesophageal echocardiogram showed severe LV enlargement with LVEF of 50%. She had normally functioning mechanical bileaflet mitral valve with severe paravalvular leakage. She had also moderate TR with PAP of 68 millimeters of mercury. The case was presented in a heart team medical session considering percutaneous closure. 3D transesophageal echocardiogram showed large paravalvular leakage from anteromedial side of swing rim in complex shape with size of about 11 millimeter. Under general anesthesia, femoral vein was catheterized. Antegrade transseptal transcatheter technique was considered as the treatment of choice. After interatrial septostomy and introducer placement with a cerebral Agilis sheath in the left atrium, a PDA occluder device size 15 mm was tried to deploy at the paravalvular leakage site, but unexpectedly the cardiac rhythm changed to the complete heart block before advancement of the device. The patient was placed temporary pacemaker and the procedure was ended. Permanent pacemaker implanted after 1 week. During a 2 month interval, she had a pace rhythm and her dyspnea was still persistent and compromising her daily activities. Hence, the patient was readmitted for an intervention addressing PVL. As she still was not a surgery candidate, a subsequent transcatheter closure was scheduled for her as the last resort, despite the previous unsuccessful attempt. The defect was passed easily with the previous method under 3D echo guidance and an Occlutech PDA occluder of 15 mm was deployed successfully with mild residual leakage and had no interference with mitral mechanical valve leaflets. You can see the final 3D transesophageal echocardiography of the patient. After procedure, patient's dyspnea improved immediately to Nihal classification of 2. She had 2 episodes of hematuria a few hours and 5 days later following the procedure, which lasted about 48 and 24 hours respectively, and hemoglobin dropped from 11 to 8.5 mg per deciliter. She received 1 unit Paxil and with the impression of hemolytic anemia. At follow-up, the echocardiography showed mild to moderate mitral paravalvular leakage with good prosthetic leaflet function and the lab data became normal. She was discharged from the hospital after 10 days in a good general condition. First PVL closure procedure failed in our patient due to possible AV node insult during catheterization. As AV node is located at the junction of interatrial and interventricular septum, PVL closures at this proximity can be complicated by CHP, but the exact mechanism of injury is not known. In an article by Cruz et al. Named Percutaneous Closure of Mitral Paravalvular Leak, Long-Term Results in a Single-Center Experience, they had mentioned 1/3-degree AV block requiring temporary pacemaker implantation in 128 transcatheter PVL closures of 96 patients. Thanks for your watching.